My slides are visible. Good morning, everyone.
Yes.
Despite, these are my financial disclosures, despite the introduction of useful treatments for the last 40, 50 years, diabetic retinopathy is still the leading cause of blindness among people in economically active age, including plenty of cases with diabetic maculopathy and chronic macular edema. Even in the pivotal randomized clinical trials, a substantial proportion of the patients are still finishing after 2 or 5 years of intensive treatment with reduction of the visual acuity below 20/50 or 20/200 and worse, particularly in transition from the randomized clinical trial to standard care. Now, a lot of work was done in real life management of diabetic macular edema. Unfortunately, majority of the studies reveal substandard outcome of the treatment and persistent poor visual acuity across the globe. Now, is low vision actually in diabetic macular edema avoidable? What we face is a substantial group of people who are still at high risk of profound and irreversible disabling visual deterioration. Use the probability of this problem. Can we identify modifiable factors? Can we adjust the management? What is the proper monitoring? Can we timely adjust the treatment? Now, what we did is to look at our own patients, a typical cohort from the Middle East. We have 83 patients who were monitored for 6 to 13 years in one place, treated by one doctor. And I actually lost some of these people because they passed away, because they were bedridden. So we need to figure out that not all patients contributed to the survey because they could not complete. What we did, we looked at their medical and ophthalmic features. Let us separate the patients into groups according to their final best corrected vision.
Excuse me, Dr. Maya, sorry, just
Yes.
to disturb you. I cannot see the slides. Anybody can see the slides? Sorry.
No, slides are not visible.
Yeah.
Oh, sorry. Oh,
Yeah,
sorry. Let us try to open again.
Yeah.
Now, okay. Now let's look at this. These are the patients. And we divided the eyes into patients who finished with visual acuity 20/40 and better after 6 to 13 years, and patients who finished with visual acuity 20/50 and less. Why 20/40? This is driving vision. This is practically guaranteeing that the patient can self-serve, read, manage with his everyday activities. 20/50 and below is usually considered borderline, and 20/200 and less is the visual acuity considered disabling in Kuwait. So what we did, we treated them with ranibizumab and aflibercept intravitreal injections, dexamethasone implants, and Iluvien, fluocinolone acetonide intravitreal implants for the last 13 years. What do we see? Let us follow the examination of the patient at his baseline visit. We found that those people who started with us with maculopathy below the age of 65 are having considerable better chances to finish with high visual acuity. So the baseline visual age of the patient is giving 1.5 odds ratio probability for good visual outcome in the end. We need them young. The level of the glycemic control. Now, this is a bit of controversial issue in the ophthalmic society. In some of the pivotal studies, it was deemed non-essential. Other studies, depending on glycated hemoglobin. So DRCRNet actually evaluated this efficacy effect of the glycated hemoglobin, and they found that it was not that significant. Now, what is the methodological issue? What they did is one measurement at baseline. And we all know diabetes is a very dynamic condition. Moreover, there are significant fluctuations in the glycemic levels. And this was actually evaluated in this huge study. And these fluctuations were actually associated with the development of significant problems in the macrovascular part. So what we did in our patients here, we found that most of the patients are actually with poor glycemic control following the American Diabetes Association criteria. And that was actually a common feature in both groups. However, dynamic monitoring by estimating the random blood sugar of the patient prior to each injection, intravitreal injection, and the dynamic monitoring of the glycosylated hemoglobin in my clinic actually found out that significant fluctuations were associated with incomplete and unstable response to the intravitreal treatment. Moreover, that these spikes and dips were actually associated with quite significant medical issues that needed to be addressed right away by the diabetology physician. Cardiovascular risk factors in disease. The risk factors were ubiquitous. All our patients practically are hypertensive with dyslipidemia, and many of them are having frank coronary artery diseases, strokes, and other major problems, and they take a lot of treatment for that. So in our group of patients, we discovered that ongoing severe ischemia is actually reducing the efficacy of the intravitreal treatment, probably from the high level of the VEGF, the vascular endothelial growth factor in the plasma. Most of the patients who have active ischemic episodes are actually presenting with persistent and recurrent macular edema. Diabetic nephropathy proved to be one of the most significant factors decreasing the efficacy of our treatment and causing recurrence of the macular edema. Moreover, once the patients were switched to hemodialysis, their macular edema is significantly less. And actually, there's no difference in the response between two vision groups. Despite the fact that these people improve after induction into hemodialysis, they're still at high risk of various complications in the eye, including hemorrhages, recurrences of the edema, and retinal ischemia. Now let's look at the eye at last. Now this patient is presenting with a lot of ischemia in her retina. I hope you can see the white vessels in the inferior half. These are anoxemic areas. The patient is having severe edema. It's long-standing, so there is chronicity and there is significant ischemia. You can see the reduced perfusion in the OCT angiography of the patient. Despite the fact that I was able to reduce the swelling, her vision did not improve over 2100 because the tissue here was having significant atrophic changes already. If the edema is around the macula, it will come macular. So perimacular edema is already maculopathy. The patients are having mild vision deterioration. However, the edema is increasing if untreated and invariably causes significant decrease in the vision. Now, this patient came nicely early with high visual acuity. Unfortunately, with ischemic conditions in his heart, we treated him aggressively with VEGF. Epiretinal membranes was there, but he had retained structure in the outer retina. So he recovered vision 2020. Very unstable patient. Now, we came to the stability of the response. Not all patients respond the same way, and not all patients remain stable. See how much this edema is fluctuating. Non-edema, high edema, high edema, no edema. And this is within very short period of time. This patient has poorly controlled diabetes, artery disease, and severe perimacular edema. Now, this patient is having chronicity as well. I hope you can see the hard exudates close to the macula, and this signifies persistent chronic macular edema. Unstable eyes are risky eyes. The atrophic changes have been repeated several times already. This happens, unfortunately, due to long-standing ischemia in the posterior pole. I hope you can see in this photograph this transparent area. This patient doesn't see here. She has significant dropout in her capillaries, plenty of microaneurysms, chronic macular edema, and she can improve tops 20/40, not better than that. The lamellar macular hole is a frightening finding. However, in our practice, it proved to be not that horrible, and we were able to recover quite nicely the visual acuity if we monitor the patient closely. This particular patient survived 2 cardiac catheterization, a bypass, and 2 marriages, and he kept his vision 20/40 despite my treatment. And the proliferative disease, there is a bit of controversy among us. There are still people who are doing laser for the proliferative disease. There are people who insist on doing intravitreal injections. And there are people who say vitrectomy is the best solution. It doesn't matter. Whatever works must be done, and the condition must be faced face-to-face immediately. Now, this particular patient presented with very poor vision, 2100. He has this epiretinal membrane, and this is the proliferative membrane at his disc. I had to complete his laser, and I had to give him several intravitreal injections. Beautiful response, however, completely unstable, despite aggressive intravitreal treatment with anti-VEGF. And why is that? Because he has ongoing artery disease, nephropathy, foot ulcers. The uveitis in the diabetic eye is difficult anyway. If it is associated with macular edema, treatment becomes even more complicated. However, it is not impossible, and we have to adjust the treatment according to the situation. This particular patient improved from 2400 to 2050, but she needed a lot of treatment. And typically for the Middle East, she will miss appointments, she will have lapses in her treatment, and we will pick up from where we left. Glaucoma is an extremely complicating condition in the diabetic eye. However, treatment is not impossible and good results can be achieved. In this particular patient, we picked up early with good visual acuity. However, the patient developed neovascularization of the iris. Her pressure went high. Immediately, the patient was referred and drainage implant was done. Pressure came down. After several intravitreal injections, the macular edema subsided. In the end, we have 20/30 vision. Very unstable. She keeps coming regularly, and she is getting good results from the anti-VEGF treatment. Not everyone is finishing this positive way. This patient came with long lapses in his treatment due to severe systemic complications and prolonged treatment for his leukemia abroad. So we lost the time when he developed all this ischemia in the retina, and he presented with advanced secondary glaucoma and severe macular edema. It is chronic. You can see the loss of the bridges in the macular edema that signifies severe and chronic disease. Even though the vision was poor, of course, we started aggressively treating him. He had a valve. His neovascularization was well controlled with anti-VEGF. The macular edema responded completely, and he is improving to 20/50 with extremely unstable response. He's having ongoing osteomyelitis associated with persistent foot ulcer. Okay, vitrectomy. Vitrectomy can be extremely useful. In this type 1 patient that we saw already for his left eye, vitrectomy was done for tractional detachment and macular edema. However, the procedure ended up with quite significant atrophic changes in his macula. I had to complete the laser here. Injections were done. There is a response, however, the vision is limited, 20/70 to 20/150. This eye managed to improve much better. He had severe macular edema with tractional detachment. Vitrectomy was done. We shouted at him a lot with the diabetology to improve his diabetic control. In the end, he finished with 20/30 with fairly good visual acuity and nice response to VEGF alone. So basically, we can find that such patients require adjustment in the treatment plan. They require close monitoring, intensive and flexible treatment. They have lapses, and we make arrangements for urgent and unexpected visits. So in the end, what can we do? We can label the patient as non-responders, give up treatment? I don't think so. We wait for the vision to drop down as our insurance company is asking. I don't think so. Or we can be a bit proactive and try to achieve better visual acuity. Now, these are our patients. In the blue, the patients who finished with visual acuity 20/40 and better over 6 years. You see the proportion of these people is increasing and stabilizing at 82%. However, those people who started with poor vision, they improved in the first year, but gradually deteriorated. Only 25% of these people were able to obtain good vision at the end of the follow-up. Now, unlike this, the proportion of people with 20/50 to 20/100, I can say borderline vision, was relatively stable. However, these people with poor vision, they did not improve a lot. However, a lot of them deteriorated to visual acuity less than 20/100. Let us look at the eyes. This eye is a female patient who presented with severe ischemic changes close to the macula few months after hysterectomy. Now, the edema is microcystic, which is a good sign. She has retained structures at the back of the eye, which is also a good sign. And despite of this huge edema in this area, treatment was started right away, and the patient improved quite well. Of course, she needed focal laser as well. You can see the ischemia is regressing. What to do with the severe NPDR and PDR in the eye of macular edema? It needs to be addressed immediately. I strongly believe in laser, and the last 2 years of pandemic proved that this approach is very useful. When people were afraid to come to us for 2 years, those patients who had pan-retinal coagulation, they fared much better than people whose laser was incomplete. Look at this eye. This patient is having macular edema. PRP, pan-retinal coagulation is done. His visual field is not that bad. And his central visual field, this is microperimetry, is showing a small defect here that is relatively not very severe, associated with this here macular edema. And why is that? Because he has retained circulation in the posterior pole. First choice of treatment, anti-VEGF's proven treatment. There are variations in the scheme, there are variations in the approach to the patient. Often the initiation treatment is limited by the insurance companies that are requiring drop in the vision. Before starting this, we need to look at the patient very clearly, and we need to see if the patient can manage to come for 5-6 consecutive injections monthly to complete the loading dose. And if it is bilateral, it's a lot. So this requires commitment from the patient and the family. There is another issue, the high cost of the treatment. For us, in this particular setting, the treatment is for free. For people covered by private insurance, there is a substantial limit in the amount to be spent. And people who don't have financial means for treatment, big issue. On the other hand, there is incomplete response in a substantial number of the patients. You see the percentage varies, and it is largest in the bevacizumab, that is Avastin. Steroids is a first choice. There are several schools that are insisting that particularly in chronic cases, in patients with very severe macular edema, in patients where anti-VEGF treatment is contraindicated, this is an excellent first choice. Agreed. However, we need to consider that both dexamethasone and the fluocinolone implants are having significant side effects. There is elevated intraocular pressure, and the cataract is starting a bit earlier. Operated eyes are difficult to manage, so treatment with implants must be managed without significant risks in these patients. Vitrectomy is recommended by several world leaders in the field. However, despite the initial good results, we need to consider the substantial complications from the procedure, and I believe these results must be verified in larger trials and longer follow-up. Diabetes and its complications, dear colleagues. Now we are coming to the essential component of our proactive approach. Often we receive the patient directly referred by the treating internal medicine colleague, and often we talk to them back because we pick up the elevated glycosylated hemoglobin, we pick up the patient in poor control, we pick up new ischemia in the eye, and often we find life-threatening conditions. Often this movement of the patient between us and the internal medicine is actually significantly improving the diabetic control. I think most of our patients deteriorated severely during the pandemic just because they were not visiting neither us nor the family people in the proper way. The first outcome of the treatment. It needs to be evaluated very carefully and without much rush. Initially, often we see a reduction in the macular edema that is not translated into improved vision. If we see structural improvement and the response is significant, let's complete the loading dose and see the visual outcome after 3 to 4 injections. There are reasons for the recurrences, and most of them are systemic. Now, this will need to be clarified with the treating physician. There are important things that we pay attention during this initial period assessment, and most of the time, the poor outcome is related to insufficient treatment during the first year. A patient who is prone to lapses, to miss appointments, to have psychiatric diseases, admitted for medical conditions and long recovery at home. Now, these patients will need long-lasting treatment despite the minor side effects. Most of the time, they will come back, and they will come back with their complications, and it will be difficult to pick up from where we finished last time. Often we need to adjust the treatment on the way. Prior to intravitreal or cataract procedures, we like to give intravitreal steroids. Before long absences, we'd like to switch from anti-VEGF to steroids. After successful vitrectomy, we like to give anti-VEGF and steroids. So it is a hybrid treatment. It is not exclusive. The first year, most of the achievement is seen here. So the aim is to maintain it. We need to extend the intervals between the treatments to a point, and we need to consider adjustments in the treatment on the go. We need to monitor the glycosylated hemoglobin, and we need to speak with the treating internal medicine doctor all the time. There are medications already available for long-term treatment. Some of them are in the process of assessment, like brolucizumab. Faricimab is giving 3 monthly results, which is excellent, extended the interval between injections. So we have to see what the Middle Eastern patient will respond to these particular options. This particular patient is presenting with 20/60 vision, poorly controlled diabetes. She just had combined phacovetrectomy, and she came very unhappy with the treating surgeon. Surgery was done very well, but the macular edema was still here. So we did 3 intravitreal injections. She had some response, but incomplete. And then we switched to dexamethasone, and she responded at last with nice vision 20/30 after 1 year. So if we come to the treatment, are we giving more injections to these people who improved better? Not at all. Actually, these people got less injections. So if we start early the treatment, we need to give less injections and we get better results. So if we look at the morphological outcome, you can see quite clearly that a lot of the patients keep persistent macular and perimacular edema even after 6 years of intensive treatment. And there is not that much of significance in the difference between them. A lot of patients are coming without macular edema at the end, and even these patients with less visual acuity are more. So obtaining structural response does not guarantee visual improvement. The response and the stability of the patients are the key. Incomplete response was much more in those people with poor vision, and that was statistically important. However, even in these patients with good vision, the proportion is not that small. The unstable visual outcome and unstable recurrence of the macular edema is predominant in our patients. However, it is much higher among patients with poor vision. So can we sort of figure out factors that are associated with the visual prognosis? Yes, from our cohort. I think the most important is the age, and age below 65 is giving better prognosis, better vision, the capability of responding completely to the treatment, and to maintain it stable. On the other hand, elder people with nephropathy, with poor vision, with atrophic changes are chronicity, chronic macular edema. With incomplete, these are the poorly compensated diabetics with cardiovascular risk factors and unstable responses. Now, these people carry poorer prognosis. Can we modify these things? Yes and no, like everything in life, right? So I strongly believe that if we detect the macular edema earlier, we give people better chance to keep the good vision. If we try to collaborate and improve the diabetic control, we are giving them a chance to a point. The coronary artery disease and its management needs to be considered a major factor that will compromise the ophthalmic treatment as well. And particularly nephropathy patients. With early induction into hemodialysis, our patients improve significantly. Now, preventing the low visual acuity is certainly possible with early detection through diabetic screening with visual acuity assessment. We have to be ready to have incomplete and unstable response. We need to be ready for frequent recurrences of the edema. We need to manage the coexisting ophthalmic pathology, and this is all in our hands. So in summary, I strongly believe that maintaining high vision is easy in real life than recovering the lost vision. With early recognition of the diabetic macular edema, close monitoring, proactive management with high visual acuity, we can prevent debilitating vision loss. and close collaboration with our medical colleagues are the key to stable and well-controlled environment that is beneficial for diabetic macular edema management. Thank you.